This is Dr. Michael Tapper from Lenox Hill Hospital and the Hofstra Northwell School of Medicine in New York City, reporting to you from the annual meeting of the Infectious Disease Society of America, or IDWeek, which is ongoing in New Orleans, Louisiana. And I'm joined by Dr. Nancy Crum-Cianflone from the Scripps Clinic in California. And you've just presented some very interesting, a little scary data on Aspergillus as a complication of influenza infection. So I'm just wondering if you can fill us in on some of the data that you've reported here.
Sure, thank you very much. The influenza season is rapidly approaching, and one thing that we noticed this last influenza season is that many of our influenza cases that got hospitalized then became infected with Aspergillus. And we've always known that influenza sets you up for bacterial superinfections like strep pneumo or Staph aureus. But what we were surprised to see this last year was that some of these patients also developed Aspergillus, typically fumigatus, invasive pulmonary infection along with their influenza. This happened in ICU patients, so patients who were very sick with influenza. And initially we thought this may just be a contaminant or not a real pathogen, but what we found in our study is that it was the influenza patients who were developing it, and it did seem to be invasive. They did have positive fungal serology markers in most cases. Patients who got bronched often had invasive looking disease, so we ended up treating them. But despite our treatment, it had a significant mortality rate. We saw a 60% mortality rate in this group. So we put together this work, and they're presenting it at IDWeek just to increase recognition that people with influenza who are not getting better or have really severe forms of the disease, that one may want to think about a superinfection with not only bacteria, but maybe also now fungi like Aspergillus, and look for it. And if you find it, consider doing further workup to see if it's invasive, and consider prompt treatment.
And were these patients who otherwise prior to influenza would not be considered immunosuppressed? They weren't cancer patients or patients with stem cell transplants of any sort?
That's entirely correct. These were normal hosts. The median age were in their 50s, but the youngest was in their 40s. None of them had any classic risk factors for Aspergillus. None of them were transplant patients. None of them were on immunosuppressives or chemotherapy. Nobody had HIV in our group. And so this is a group of patients which we typically think are not at risk for Aspergillus.
Absolutely.
But we hypothesize that maybe the influenza lowering the immune system, causing lymphopenia. We found lots of patients had lymphopenia around the time of their influenza infection, then set them up for potentially developing Aspergillus in this setting. And so we think this may be a new group where there is now novel risk factors for Aspergillus in an otherwise normal host.
And were there any other commonalities? Had any of these patients received corticosteroids either by inhalation or parenteral oral corticosteroids, something else that might explain this peculiar susceptibility? As you say, this is very unusual. I'm sure it's been reported somewhere previously, but this is an unusual finding. To have a cluster like this would raise the question, of course, of nosocomial infection, which they probably did acquire within the hospital. But I'm curious if are there any other medication histories that might have predisposed them that would be warning signs for other people. Steroids sometimes given to people, for example, with ARDS who have severe pneumonia as a desperation move.
So we looked at this. Only one of our cases had gotten steroids previous to the diagnosis of Aspergillus. All of them really received a broad-spectrum antibiotics, which also may be considered a risk factor because you're killing off normal flora, and then that may provide an avenue for Aspergillus then to not only colonize, but also then become an invasive infection. So I think one of the lessons this teaches us is that unless you have to give steroids or broad-spectrum antibiotics in flu cases, that maybe it's better not to, because you might be increasing their risk for Aspergillus. We did look at patients within our hospital setting who did not have influenza, and we did not see any Aspergillus cases. So we do not
construction going on, none of the
nothing
things that
else going on that would have associated with Aspergillus, right? So we thought that there was a real correlation between the influenza and Aspergillus, because it was only in these patients that we saw these cases. In addition, because we thought this originally might be just a contaminant or not a real finding, we did a thorough literature review, and we looked back at the literature to say, are there other cases like this described? And so going all the way back to the beginning of PubMed, we looked at cases, we found 52 other cases in the literature, and we summarized those and evaluated those and analyzed those. We really couldn't tease out risk factors of why this happened in these specific people.
Or clusters like this.
And there really wasn't a lot of clusters
Yeah.
either. So I think what we need is better studies and some case control studies to look at this further to see what are the true risk factors, because it was really hard to tease out with these single case reports. And we in our study could not find an exact link of why these patients developed Aspergillus.
Fascinating and scary.
Yes.
Thanks so much for sharing with us today.
Thank you.